interest in the last couple of years. As you already mentioned, I'm working at the University of Zurich, and my disclaimers are there is nothing that I have to disclaim. So let's jump right into it. I think it's still important for me to give you some context of my work and what it was that spawned my interest. So obviously you will have some ideas of what it means to be in Zurich. So Zurich is in Switzerland, and you will also have some idea what it means to be in Switzerland and practicing psychiatry or medicine in general in Switzerland. And it means that you are in a predominantly white and overall very affluent context, and you have very easy access to all kinds of medical care, including mental health care. So whatever you want, basically, you can have it, and there's no practical limitation on the medical care in any way. So I think that is very different from the contexts where most of you as attendees of this talk actually do practice medicine or psychiatry. So and I think it's important to understand that because I think I'm interested in palliative psychiatry because at one point I realized, okay, even if you've got arguably the most resourceful context in the world, you still have patients that won't miraculously get better. And you can't solve all the problems, even though you've got everything at your disposal that practically exists. Okay, my story in psychiatry starts in 2006 when I started my residency at the university hospital there in Zurich. And I already said what the context is. And in the first couple of months, I had to take care of a patient in her 70s with a psychotic disorder, and she still holds the record of most inpatient admissions of any patient that I ever cared for, because when I had to take care for her, it was 141st admission to our hospital alone. So she might have been admitted to other hospitals as well. So it might well be that during her course of illness, she might have been admitted up to 200 times. That's well possible because there are several psychiatric hospitals in Zurich, obviously. And she had an enormous patient chart, so some of it was still stored in our hospital, that it was about 1/2 meter of paper printouts or just a paper file, because by the time, obviously, we were not fully electronic, so much of it was still on paper. And most of the patient chart that obviously went back more than 50 years was in the archives of the state. So we were, in this case, I didn't even ask for it to be transferred to us. But the overall question obviously is what to do with such a patient, because everything has been done, arguably. My consultant at the time said, okay, don't fall into hyperactivity. Don't try to solve something that many people have tried to address before, and accept the futility of what you're doing. And by that time, I just, this was what I had to do, what I did. I didn't really reflect on what it was, But in 2013, a colleague of mine and myself then had the first publication on palliative care in psychiatry in the Swiss Medical Journal. And but I didn't basically combine these ideas. Only when I myself became a consultant in inpatient old age psychiatry, I realized, well, I'm constantly on the defense with what I do, because I never really heal or cure anybody. People, especially in the inpatient ward where I was the consultant, or in the two wards, where, let's say, the severe cases were clustered. Not so much, let's say, simple sleeping disorders or depression or some pain, but rather advanced dementia, very severe psychotic disorders, and disruptive behavior of all kinds. But on the contrary, approximately 5% of the patients deceased while they were in my care, which is comparable to the acute geriatrics wards that we have in Zurich. And oftentimes these were, for example, patients with very advanced dementia that could no longer be taken care of in nursing homes, or people with very severe somatic disease that have been in regular hospitals for various somatic illnesses and delirium, and could no longer be taken care of in those. So we got a highly selected patient population that eventually never seemed to really get better. We only helped them somewhat, and in some cases really provided even terminal care. So this is my background, and the question now obviously is, why should we care, or what does psychiatry have to, palliative care have to offer for psychiatry, and what is the connection? And I'm going to try to introduce you to some of that thinking. Well, first of all, psychiatric disorders massively increase mortality, and some of them can be fatal themselves. So I put up some classic epidemiological studies here. So that is true for depression, that's true for eating disorders, that's true for addiction, that's true for schizophrenia, and for other, basically for all other major disorders in psychiatry as well. It has been shown in schizophrenia. I think that's even particularly noteworthy, that the mortality gap to the healthy non-schizophrenic population even appears to be increasing. So while overall we live longer, patients with schizophrenia do not benefit from that increase in life expectancy. And obviously they live shorter just for having their psychotic disorder and suffering from its consequences. The other, let's say, building block for this argument is that there are limits in psychiatry, and I just want to make or put forward here depression as an example. So this is also classic data from when I started in psychiatry. It was just being published, the STAR-D trial that looked at sequenced treatments in an algorithm for depression, and basically the authors tested various combinations of antidepressants and eventually also added CBT. And after every treatment step, you see here down there, you have an increase in the cumulative remission rate, but even after the fourth step, you do not reach 100, but it actually levels off below 70. And if you put in ECT and do a high dose bilateral ECT, which you see on the right hand side, and This is also a classic study that looks at different modalities of providing ECT. So let's say the more aggressive ECT forms are on the right of the chart. You still see that even in the final response in not resistant or in medication resistant patients, you do not approach 100%. In this case, not even remission, but response. So even if you use the therapy that is that can be rightfully considered the most effective, but also the most aggressive form of treatment for depression, you will not cure or everybody, and you will not even have response in everybody. So I would argue that even within psychiatry, we ignore these limits. So I argue we can do a lot of good to a lot of people, but there are some people we can hardly help, or some that we can't help at all. However, we still do or tend to do the same all over and over again, at least in the context of my practice in Switzerland, where there's an abundance of resources. So people just stay in the psychiatric hospital longer. They get more medication. They are augmented. Eventually, they will get ECT, and still some people do not get better, but then we restart and do the same things all over again. And in the process, we also tend to become ever more aggressive in our treatment approaches, because we think, okay, we need to escalate, and then we prolong, we extend the ECT series, etc. And I think behind it is also some, let's say, silent stigma that we do not admit to ourselves, that we ourselves have towards mental illness. There's some therapeutic omnipotency that is behind it. We also think it's only in the head, and we just have to keep trying until eventually we will find the key to solve this clinical problem. That is one way to deal with these treatment refractory cases. The other way is just to say, okay, we can't do it. We have done that before. We will not try again. So we ration care, and we give way to resignation. And why do we do that? Because we lack established alternatives. We need, and that would be the conundrum, and I think this is where palliative psychiatry is situated. The question is, how can we help a patient where our therapeutic attempts have not helped? So how can we provide help where we couldn't before? And there's some other problems that arise at these limits of psychiatry, because we do not have established rules or procedures for our decision-making at these limits. They tend to be not rational and not transparent. So if we escalate or basically stop care or continues to do the same thing, does not depend on any kind of rational decision making, but basically depends on who's in the room and their personal experiences, which obviously is also good, but that does prevent a form of shared decision-making where you can really base or share a reasoning with the family, with significant others, and with the patients, with everybody involved, and then come to the best way ahead. And eventually, another problem is patients are abandoned because we can walk away, they can't. And the problem can be stated as such. We do not have an adequate care offer, I believe, beyond the limits. So for schizophrenia, it's the old problem. What is it that comes after clozapine? Or some people say all psychiatry ends with clozapine, and there's some truth to that. And I think it's also an important reimbursement of care is also an important issue to keep in mind, because we do things that we need to justify in front of the medical insurance companies, and how can we justify being there for the patients if we do not have an evidence treatment that we can offer some kind of standard of care. And all this is, I believe, where palliative psychiatry should enter. And this is what it's meant to be. And the question is, what is palliative care? Well, it's one of the pillars of medicine, besides prevention, curation, rehabilitation, and the fourth pillar is palliation. And if you think about it, obviously we have preventive psychiatry, we have curative psychiatry, we have a lot of rehabilitation in psychiatry. But I think, and this is the whole point of this talk, is we have very little, at least very little palliation that is called palliation in psychiatry. Now, what is palliative care? There's a WHO definition that says palliative care is an approach that focuses on the quality of life of patients and their families in the context of life-threatening illness. And it looks at the assessment and treatment of pain and other problems, and it embraces, and I think that's also good to know for us in psychiatry, it embraces a physical, psychosocial, and spiritual approach, very close to our psychosocial model, biopsychosocial model, obviously. The origins of palliative care are very much linked to the person on the upper right-hand corner. That's Dame Cicely Saunders, who, due to her experiences during and after the Second World War in London, said, well, we need to have some kind of care for people who are very ill and dying. And she did not call palliative care, or what she did, palliative care by then. And she also, so she did not practice palliative care under that name, but she promoted the idea behind it in her publications, and mostly through her vast traveling around many places in the world. She also traveled to Canada, and eventually there an oncologist coined the term palliative care for an inpatient ward, where he took care of patients. And in 1990, the WHO then adopted the term and therefore officialized it as a global area of action. And due to these historic roots, there's obviously a very close link to oncology. But in the last decades, palliative care, as you know, has moved way beyond oncology. And it has also moved beyond being mere terminal care. So modern palliative care does not start when everything is already going towards death. So it's not only covering the dying phase, but in the modern understanding of palliative care, it actually starts already in the phase of acute illness, when the severeness of the disease is lower, but its importance obviously increases over time and over the course of the disease, and the disease modifying efforts that really aim at curation or rehabilitation become less important when people approach their dying phase. And people would also argue, so palliative care specialists today would also argue that their job does not end at death, but a good palliative care also involves covering at least some part of the phase after death, and preventing or helping in bereavement and preventing pathological grief. Now, is that only a nice concept? No. And that this publication from 2010 really shook up the palliative care scene. So what you see here is a trial where early palliative care, so an intervention that started immediately after the diagnosis, not only in the dying phase, actually had an impact on the survival of patients. In this case, with metastatic non-small cell lung cancer. And if you really reflect on it, and everybody says, well, that's highly plausible, because if you talk to patients and take their symptoms seriously and try to alleviate their suffering, and help them getting through their lives better, then obviously their chances of survival and even to such basic things as treatment adherence will be better. And you see that, you see a survival advantage that for that group was actually massive. And this provided really the justification, the evidence base for early palliative care in this type of lung cancer. But it was also a proof of principle for saying, well, there's more to palliative care, and particularly early palliative care, than just feeling good and providing humane care, let's say, but there's also hard benefit in that. Well, what's in the box of palliative care? If you talk to people from palliative medicine, they often say, well, palliative care is a mindset. And it involves a partnership in planning the therapy. It involves prioritization of symptom reliefs. It involves avoiding futile but harmful interventions, so overly aggressive care. It's a highly creative approach. It is something that we do together, and often you then hear mentioned pastoral care. So the priests that are affiliated with the hospitals become involved. And what people really often make the point is that terminal care, so care in the dying phase, is just one part of palliative care, but it's not by far not the only thing that is meant by palliative care. Well, is there already some common ground between psychiatry and palliative care? Yeah, I do think so. We both employ the biopsychosocial model and also put the spirit in there, even though I think the spirituality part is usually, or in my experience, much more accepted in palliative care than in psychiatry. I do think that autonomy and patient-centeredness are core elements both in psychiatry and palliative care. You may also reflect on the fact that we have advanced directives. So people do that in order to determine their wishes and transfer them in case or for their end-of-life care. But such advanced directives also exist in psychiatry. Yeah? And these are, to my knowledge, the only fields of medicine where this is practiced. So for example, I've never heard about an advanced directive for ear, nose, throat, for example, or eye medicine, or any other kind of medicine. It's either end-of-life care or psychiatry. Then in medical education, psychiatry and palliative care are often the only talking specialties, while the others are much more technically oriented. We're working in teams, and we receive supervision, we have Berlin groups, etc. And actually, when a palliative care ward was opened at the University Hospital in Zurich, I went to the opening event and thought, okay, what they actually did now is open a psychiatric ward with bad staffing and little resources. But overall, we both specialties have a less technical environment than the rest of environment. And another similarity is we provide outreach. So community outreach teams and the like are obviously an important feature of psychiatry, but mobile palliative care teams are also largely established in many places. Other common grounds is the use of psychotropic medicines, because we address the same kinds of or similar kinds of syndromes. Think of depression, fatigue, anxiety, delirium, hallucinosis. We both use psychotherapeutic approaches, and you may know that there's even a specific psychotherapy in palliative care that is called dignity therapy. Then we share psycho-oncology, but I have to say, in my impression, this is largely relegated to psychology. So we abandoned that. Very few psychiatrists do psycho-oncology. But if you really make up the numbers and count psychiatrists versus psychologists who are in psycho-oncology, I would say we are outnumbered by maybe 10 to 1 or even much more. And we share the difficult discussions about assisted suicide, about MAID, and many other things, I think, where we do have common grounds. Well, now the 4 use cases. Who would need palliative care and psychiatry? There are theoretically and practically 4 combinations. There can be a somatically ill person who turns, and I would call that somatically palliative. So that would be a case for a traditional palliative care, and we probably don't need any involvement of psychiatry at all. Then we have the somatically ill person who turns somatically palliative and develops some mental health issues. And that is still traditional palliative care, I would say. And then we've got additional assistance by the field that is called psycho-oncology. And now it becomes interesting, because there are also, I believe, mentally ill persons who turn somatically palliative, so who become so ill somatically that they require palliative care. And I think there's a service gap. And this may be where palliative psychiatry can enter. The other use case would be a mentally ill person who turns psychiatrically palliative, and I also see a service gap there that may be covered by the field of palliative psychiatry. Yeah, and we did publish on that. We first came up with that idea in 2016, had a letter to the Lancet, and then follow-up article in BMC Psychiatry. So if you want to read up on that, it's here. And we provided a working definition of the palliative psychiatry, where we based ourselves on the WHO definition. And so this is it. I think if you still have a little bit in mind the definition of palliative care by WHO, we basically followed it a lot. It just put in there that it's directed towards patients with a life-threatening, severe and persistent mental illness, SPMI, and the last sentence that it focuses on harm reduction and on avoidance of burdensome psychiatric interventions with questionable impact. So we do not want to overtreat. And we also defined some features of palliative psychiatry. I just want to basically focus for a little bit on the blue ones. It affirms life, but acknowledges that SPMI can be incurable. I think it's important that we are realistic in that aspect, that mental illness can lead to death. And I'm allowed to say that aloud and even talk about it in front of an audience. And that does not mean that I'm giving up on patients, but it's the recognition that mental illness is not harmless. Palliative psychiatry does not intend to either hasten or postpone death, but it accepts death as a reality. And the last bullet point here is applicable together with other therapies. So it does not understand itself as an exclusive approach, and it does not understand itself as being in competition to other approaches, but rather an addition. Well, that sparked some interest, so that triggered basically an entire edition of on palliative medicine in the Nervenarzt, which is the largest German-speaking psychiatric journal, in 2020, and we also had some other follow-up articles, so by other people. So here, people who try to explain what the difference in the approach is between curative psychiatry, rehabilitative psychiatry, where the intervention is rather directed, as you indicated by the green arrow, towards psychosocial functioning, and then palliative psychiatry, where it may be directed towards harm and suffering. But I do not think that these people fully hit the nail on its head, because I would strongly argue in favor of saying that that palliative psychiatry, whatever it means or whatever it does, is directed towards symptom reduction. And even as we speak, in the current edition of JAMA Psychiatry, so this month's edition, print version, so you see September 13th, but this is the date it was published online. It's in the current print version is this viewpoint on rethinking palliative care in psychiatry. And obviously you can't go into the text right now, but what these authors aim at is access of palliative to palliative care for patients with severe and mental illness. So it is something that that I think is in the air right now, and also we ourselves have had quite a good uptake. I think one of the problems is that thinking about it for years now, and this is a question that is still unresolved, is what is the target patient population? And I would say, well, it's therapy refractory disorders, obviously with a long disease course, low functionality, high symptom load, and high degree of suffering. And these may be specific cases of anorexia, psychosis, depression, substance abuse, but also in other cases. OCD could also be an example, or other psychiatric disorders. And but I think it's important to, or whenever I think about the target population, but I have not come around to really have a good marker for that, is that these people are too ill to recover. And then people who are staunch followers of the recovery movement would obviously answer, everybody has the potential to recover if we don't hold them back. And this is exactly what I do not believe is the case. So I believe this target population is people who are actually not healthy enough, and arguably will never be healthy enough to find the strength for recovery, because it requires a lot of autonomy, it requires goal setting, and it requires also a lot of endurance. And some people, in my experience, do not have that kind of resourcefulness. And we initially, and then also going on, we thought of severe and persistent mental illness as the target group, and we did a follow-up publication on exactly that, since we tried to find out, well, what is it that we claim is the target patient group, and it turns out nobody knows, and it's actually impossible to define. So that was a dead end, but that's also a highly cited dead end. The other thing that we did is we asked Swiss psychiatrists about what they think about palliative care and its link to psychiatry. The first question here that I put up for you was if Swiss psychiatrists thought that the term palliative was directly related to end of life. And that, as you see, was a mixed picture. So somewhat yes, but overall people do not strongly associate that to the end of life only, which is, I think, good. And then many psychiatrists were also agreeing on the fact that a palliative care model would be important in order to provide optimal care for certain patients, even without a life-limiting medical illness, implicitly saying that many patients, also psychiatric patients, would be a suitable patient group. And then we went on and asked more specifically who thought that for severe chronic and therapy refractory anorexia, schizophrenia, depression, bipolar disorder, and substance abuse disorders, a palliative approach would be suitable, and people are actually open to that. That obviously encouraged us. The question is eventually, why do we need a palliative psychiatry? I think it allows a way forward to lets us radically side with the most severely ill patients. It extends the limits of our specialty and works against our helplessness. And it also offers a conceptual justifications for being creative in the most standard, in the most non-standard cases. And it makes us more open to learn from palliative care, because this is a field, palliative care, that highly successfully has developed in the last 50 years, let's say. and we practically ignore what they're doing. That's my impression. And I also think it very much has the potential to improve the image of psychiatry. And I'd like to spend a little bit about that because palliative care is actually frequently perceived as humane medicine that in the face of human death eventually lets aside this industrial medicine that all of us practice, and in the last moments of one's life, then turns to the right kind of medicine, which has more human touch, let's say. Well, psychiatry, on the contrary, I mean, we're the bad guys of medicine. That's at least my impression. We're continuously in the defense. We're either perceived as too aggressive, too much compulsive care, or we're too soft, we do too much talking, we do not have enough evidence for our treatment, or then we're being criticized for too much evidence medicine, so we only do the meds because there's evidence, but we forget the person. And so whatever we do, we're never on the right side. And think about these examples. So, for example, the infamous supportive psychotherapy, people do that, and I strongly believe it's the right thing to do. So, without a clear, let's say, achievable, smart goal of psychotherapy, there are a lot of patients that are just, they need our continuous support. And but how do we justify that, especially against or towards the reimbursement authorities? Or think about the long-term treatment with benzodiazepines. It does happen, and it's hard to justify, but some people, I have a lot of colleagues would say some people need it, and we can argue about the individual cases, obviously. And I would advocate for palliative psychiatry as being a way to, as I said before, radically side with patients, and therefore promote the humanistic, person-centered core of psychiatry. And that this is obviously easier to do with a dying patient. So for, let's say, conventional classical palliative care than with the aggressive patient that we deal with on a daily basis. I think that's obvious, but that it's harder maybe doesn't make it less true. Then there are controversies and critiques of the concept. Well, I hear that over and over again, and I'm really frustrated by that, because whenever I talk to a psychiatric audience, then I hear, well, palliative means giving up. And I'm frustrated by that, because this has been said in somatic medicine for decades, and somatic medicine has moved beyond that. Doing or providing palliative care does not mean giving up on patients. I think that is very clear. And the second thing that I always hear is that palliative care would take away the chance for recovery. And as I mentioned before, I do not think that these approaches are really competing with each other, but they are suitable for different patients groups. I think that is a core issue. So that leads to the question, which are the patients? And I think a major problem that we have in psychiatry is that we lack we mostly lack a staging system and a prognostic system for our disorders. So think about cancer care. So you have the staging and grading systems of cancers, and this is what really made the advances in cancer treatment possible, because you would not treat a stage 1 cancer in the same one as a stage 4 cancer. But still, we do treat an opioid dependent patient the same, or the evidence base or the guideline does not differentiate between somebody who has different stages, simply because there are no different stages of opioid dependence, for example. So we don't know when futility is reached, and this is obviously an important criterion for everything what we do in palliation. And then I think, and this is another real issue, is how do we deal with autonomy as being a core feature of palliative care? So in psychiatry, as we all know, decision-making capacity is often impaired, especially in the kinds of patients that I'm thinking of as target patients, and this is very different from palliative care of the somatic kind. And we also published a nice case report on that, where we thought treatment success consisted actually in enabling a person to regain decision-making capacity, which then put her in a position to commit assisted suicide, which obviously is very much contrary to what psychiatry in other contexts would ever advocate. Now, how to move forward? One thing that we do at the moment is we perform participatory research. We've got a project going on with the most severely ill patients that can be found in Zurich. So these are patients that are in a hospital that is specifically dedicated to dual diagnosis, meaning mental illness, substance abuse, and somatic illness in this case, who are often homeless and socially disadvantaged in any way you can imagine. And we established a participatory research project aiming at finding out what they think about palliation, what it means to be healthy despite of all these load of illness. And this is an ongoing project that we do. So I asked people what they think, and on the, let's say, more academically straightforward side, I would be very happy to collect best practice examples, because right now there is no established canon of palliative intervention. So we don't really know what palliative care in psychiatry is. So we can define it ourselves, and therefore we would need to collect use cases, and by that way define what we think is palliative psychiatry. We want to organize a conference, found an interest group. The problem that I encountered with that is there are actually some people who practice psycho-oncology, and they already have their interest groups or scientific sections in the scientific associations, for example, WPA, and they're not interested in or even are, let's say, openly hostile to the idea that there might be another kind of palliative care and in psychiatry rather than what they do, psycho-oncology. Then eventually create a scientific society, and in the long term, just do the trial and find out, just like this early palliative care did in non-small cell lung cancer, if we provide psychiatric palliative care to chronically ill psychiatric patients, well, what is the outcome? And even if we don't do that, I think it's important to do advocacy. If we're not able to or willing to embrace palliative care in psychiatry, then we should at least advocate for more access for our patients to what is now palliative care. Then to summarize, I think psychiatry has its limits, and to our detriment, we tend to ignore them, and even worse so, to the detriment of our patients. Many things that we already do in psychiatry could even be considered palliative. However, we do not call it that. So think, for example, of long-term opioid substitution. That is clearly not a preventive, at least not primary or secondary preventive measure, and it's clearly not curative. I think approaching or embracing a palliative approach in psychiatry would enable us to work with patients beyond the limits of our field, and certainly a lot of groundwork still has to be done to promote the idea. And I already talked a lot. I can either stop here or I can still present a case and we discuss afterwards. So I would leave that up to you.
I'm happy to hear your case. So
okay, so I'll add 5 more minutes for the case, and then we enter the discussion. Okay, I'm presenting one case here. It's a 64-year-old white male who was admitted to my psychiatric ward with a compulsory admission, so he was sectioned. And this person, from the admission note, I translated that directly, and you see that here in quotation marks. So that person has been living in our nursing home for 4 years. He was admitted to our nursing home from a Salvation Army shelter because there he was too disruptive due to his excessive consumption of alcohol and verbal aggression. At the moment, he does not cooperate and does not take any medication. He rarely allows nursing care. In the last couple of months, there was increased alcohol consumption and explosive verbal and physical aggression against other residents and staff members. He repeatedly hit a resident in the face and could only be contained by the police. He's a ticking time bomb. So that's from the admission notice. So I would say, well, this is classic psychiatry. Yeah? So this is a mixed bag of everything and a lot of aggression in the mix. And upon admission, that's what we see. The patient considers himself out of place in psychiatry and immediately approaches the court to protest his compulsory admission. This protest is eventually turned down, so he needs to stay with us because the court found he was a danger to himself and others. The patient, upon admission, claimed to drink 3 to 4 cans of Gralsburg beer per day, so about 2 liters, but arguably that was more. He claimed to only have solid food at night, and that was because he frequently had to vomit and had liquid diarrhea 7 to 8 times a day. That's also why he always needed to have a toilet close by. He reported on weight loss of about 30 kilograms over the course of the last 8 months, and we could verify that from the nursing home charts. Patient denied to be physically aggressive and said that he had other people who would do that for him, so he wouldn't need to do that himself. And we saw a cachectic patient that was wheelchair bound at the admission exam, and the liver was palpable in the physical exam. And if you basically get the picture, and now I think there's some work up, there's some differential diagnosis and some things that need to be done in order for it to be brief. I put it all together. So obviously there's alcohol dependence, or there's an issue in that field. So a classic job that would be for psychiatry would be to withdraw the patient. Then there's pancreatic insufficiency, and we would need to check for elastase, and if that is confirmed, we would need to start the substitution of pancreatic enzymes orally with every meal. Then there's a high level of a suspicion for gastritis, and so we would probably need to do a gastroscopy and start with a proton pump inhibitor. And then there's also suspicion for esophageal varices. So again, gastroscopy and possibly an endoscopic intervention. Hepatic disease, obviously, ultrasound, maybe also intervention. And there's malnutrition. So we have, and that to an extent where there's risk for refeeding. So we somehow need to get nutrients into the patient. And this patient is sarcopenic. He's highly deconditioned in the wheelchair, so we need to start physical therapy. That's the theory, and maybe even more that we didn't think of. But these were the different, let's say, lines of actions that we thought we would need to pursue. And then theory meets the practice. And we had an 8-week period of hospitalization, and the patient just wanted to continue drinking. And then we negotiated and said, okay, but instead of 4, you only do 2 if you can. Well, he agreed he could do that. So we went to the supermarket and bought some Gralsburg Pilsner. And when I took the beer cans from the parking lot of the hospital, actually had some comments from colleagues, etc. It's an unusual sight to bring beer into the psychiatric wards. And the patient refused medication and did not eat at all at the beginning of the hospitalization. Eventually accepted ultrasound. We found no tumor, but some fatty liver disease. Eventually, he accepted phosphate capsules in order to prevent refeeding syndrome. Then we negotiated again and got him to take those dissolvable multivitamins instead of the phosphate capsules. And after long hours of talking, he was willing to accept also dissolvable PPIs. Which then led to the vomiting to cease. And then we went to get the favorite spicy salami, a Spanish version from the supermarket, and he started eating. And then eventually he was with the food at night. He was willing to accept some pancreatic enzymes, which led for the diarrhea to stop. And at that point, we found him a new nursing home where drinking was tolerated, and he was not completely burned as a person as he had been before. They were unwilling to take him back. due to his aggression in the past. Well, some reflections on the case is here. Is that a valid job for psychiatry? If it isn't, well, who should be doing it? Do these people really go to somatic hospitals? Do nursing homes do that? Was that a disaster of a treatment, or was it a success? Was it the right treatment aim because we did not withdraw that patient, for example? Was it palliative, following up on everything that I told you? Well, what about the patient autonomy? Eventually, he refused treatment, but he was compulsorily admitted, and we certainly used a lot of convincing. And in favor, I would say, or as another reflection, is that psychiatry is very good at enduring difficulties, and that's what we did. And we did not abandon this patient. And I think another quality of psychiatry as a profession is that we can decide not to treat in certain situations, as we did here, or as we did here, we treated differently. And that's again it. Now I'm at the very end of what I could say here. And please, if you want to have an overview, then refer to that article, which is open access. And I'm really happy if somebody is interested to take palliative psychiatry forward, to exchange ideas and maybe start a collection of cases, etc. And I'm happy to discuss with you.
Yeah, I think thanks a lot for this really enlightening talk, and yeah, I think it's very new and different thinking. I think we very often have such cases, and especially when you work a little bit in locuming here in this country, you see patients where you sometimes are in a position where you think, should I do something, or what have the other colleagues done? Have they, people who are very often stopped on Suclopentixol, and they're still, they're more or less, nothing is done anymore because everything has been done. The other thing is we very often don't have any, or we don't have all the tools of psychiatry. I don't know how it's in Zurich, but we don't have ECT, we don't have TMS, we don't have agomelatine, we don't have ketamine. So I think sometimes we have to make these decisions in an area where we don't have all the tools. So the question, so that's one thing, what limitations of the service are. I think my anxiety would be if the services becomes too pessimistic, then they don't make the progress in these, what we heard yesterday, in psychedelic treatments or other things. So I think that's one of the things where I sometimes come in and think, what is it? And the second, maybe you can comment on that. And the second point is, how would you speak differently to a patient who you see more or less, yes, in a bit palliative way in your concept, or where you still have some rehabilitation, or where you still have some hope for recovery? So would that change your attitude and your way of dealing with the patient?
I think the major change that I perceive in myself is I think it takes out the pressure. Because I myself put myself under the pressure of wanting to achieve something, the need to improve. And if I allow myself to consider a situation as a palliative situation, then I accept stabilization as already a gigantic success, and slowing of decline as perfectly acceptable. And I think by taking out the pressure, it also enables me, at least, and I would argue us in general, to listen more. And I think that it makes all the difference. And listening more then enables us to become more creative. So, I mean, I would have probably, people would, I would have probably flunked my residency if I told in the board exam, well, I go to the supermarket and buy some cans of beer and bring them to my inpatient ward. Yeah, so that's my plan for treating alcohol disorder here. Yeah, I think that is can be considered absolutely, completely and clearly wrong, but it's a creative way of dealing with a real life problem. Yeah, it accepts the reality, I would say, and I think this is it. It takes out the pressure of doing the right thing, and what we all know from the guidelines. And there's always this discrepancy. People always say, yeah, the guidelines, they do not cover real life. I think they do. There's no doubt about it. And using that as justification why we don't follow the guidelines, I think is wrong. But I also think that everybody who's saying that has a point to a certain extent. So that would be to your second comment. And to your first comment, so in Zurich, the therapeutic options are practically limitless. It would require some negotiation, some logistics, etc., for people to offer these kind of more, let's say, exotic treatments or expensive treatments that you mentioned. But I think this is exactly the problem that we have to move forward with the field if we want to establish. We cannot draw the line too early. I mean, if you say after fluclopenticol, then people are they are palliative if they don't respond to that because we don't have the other options. Yeah, then this is certainly problematic, to say the least. Yeah, but still, we in any case of care setting, we would need to be realistic of what we have at hand. Yeah? And maybe if adopting a palliative mindset would prevent you from ever increasing the dosage of the medication or adding another bit of haloperidol, etc. As we all know that happens, then this already would, I think, be a huge benefit of palliative psychiatry, because I think it creates a justification. Yeah, because it does not, adopting a palliative standpoint takes out the pressure, as I said, and obviously we have to always weigh that against realistic therapeutic options if they exist. Yeah, then it is not, and it's not meant to be an exclusive approach.